This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters, heart disease remains the #1 cause of death in the United States. While lifestyle changes can make a difference for many, some heart conditions are out of our control.
It was determined that the hormones while I was pregnant damaged my heart.
It was news Katie never expected, but it came with a message she now shares with everyone.
I think that's the biggest thing we all need to remember. Listen to your heart.
Your heart health questions answered live by our panel of experts. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
Good evening, I'm Teresa Lukens, and welcome to Health Matters. Almost half of adults in the United States have some form of heart disease. Conditions include coronary artery disease, high blood pressure, cardiac arrest, and congenital heart defects. Here to share their expertise and take your questions live is our panel of experts. Dr. Muaz Abudiab is with Providence Spokane Heart Institute. He specializes in preventative cardiology, cardiac risk assessment and management, and cardiovascular imaging. Dr. Jeremy Nicolarsen works at Providence Center for Congenital Heart Disease. He is director of the Providence Adult and Teen Congenital Heart Program in Spokane. PACC is a nationally accredited ACHD comprehensive care center. Dr. Eric Wallace is a cardiologist with Kootenai Heart Clinics Northwest. He specializes in interventional cardiology with a special training in structural heart disease and peripheral vascular disease. He is also the medical director of the Heart Clinics Northwest Vascular Laboratory. And Gretchen James is a certified physician assistant at Providence Spokane Heart Institute. She has over 20 years of experience in cardiology and working in heart surgery. And we welcome you to the program tonight, and we welcome your questions by phone or email. We also want to remind you that we are streaming tonight's program on the KSPS Facebook page. And panel, thank you so much for being here. An important topic. It is Heart Month, and the numbers can be a little startling, Dr. Abudiab, but it is also worth noting that less people are dying in the last 50 years, even though it is still the #1 killer.
That's absolutely right, Teresa. So although the cardiovascular deaths in the United States have decreased over the last several decades, and that's due to multiple causes, increased public awareness, improved preventative measures, including improvements in medical therapies, as well as advancements in techniques, balloon and stent procedures for coronary heart disease, improvements in heart failure treatments, etc. But although that's promising, the sobering fact is that actually in the last couple of years that trend has kind of plateaued, and in fact there are some signals that it may be reversing with the obesity and diabetes epidemics that the U.S. is currently facing. And so I think we certainly still have our work cut out for us.
Mm-hmm. So certainly lifestyle changes. We're going to talk a lot about that this evening with the topic of heart health. What are some of the different types of heart disease, especially in men, and then we'll have Gretchen touch on some of the heart disease for women?
Yeah, well, traditionally, men tend to suffer more from coronary artery disease. It's a common disease that affects them, and symptoms may be decreased exercise capacity, chest pain, shortness of breath when they're exerting themselves. Those are symptoms that we typically think of, and so that's something that affects men. People with coronary artery disease also can suffer from congestive heart failure, or they may develop that as an unrelated problem. So there's different aspects, anything from blockage related to just failure of their heart, and so each one of those has a different treatment, and it's a complex thing to manage.
Mm-hmm. What do you mostly see in your office?
Well, my practice is fairly diverse. I practice in North Idaho, and so I do see a lot of coronary disease. I'm an interventional cardiologist, meaning I specialize in emergent procedures to treat heart attacks with stent procedures. So a good portion of my population is that. But like Dr. Abudiab, I do see patients with hypertension, high cholesterol. I do preventative cardiology, and then I do manage some of the other peripheral vascular disease, which is also common because it shares a lot of the risk factors for coronary artery disease.
And then for women, it can be actually different. We're finally learning that here in the last few years, that women can present differently with the different types of heart diseases.
Yeah, there are different types of heart diseases that women have, but they also present differently as well. Specifically, some heart diseases that women experience that are more specific to women include broken heart syndrome, coronary microvascular disease, and spontaneous coronary artery dissection. Also, women tend to have higher risk of having a stroke when they have atrial fibrillation than men do, and there's certain other things too, but they're a little bit more specific, and I think we'll see more about a specific case later tonight.
And then Dr. Nicolarsen, you work with a very specific group of patients.
I do. Most of what you heard about so far are acquired heart diseases that develop later in life from a myriad of causes, but I take care of people who were born with heart defects. And many of those patients 50, 60 years ago would die. They wouldn't survive to adulthood. And now it's quite common for these patients to make it to adulthood and then to need cardiac care that's specialized for their particular heart defect. And a lot of the providers out there in the world don't see this commonly. They're not as familiar with it. And so now there are specialists in cardiology who specifically deal with congenital heart defects.
And you actually have some concerns about a population of people that aren't seeking care because they believe they were cured when they were children.
Absolutely. We hear it all the time. It's quite common for patients to get surgeries when they're young, to have some improvement in their overall quality of life, to see a pediatric cardiologist through childhood, and then maybe to go off to college or the workforce or Hollywood and be out of care after that. And it's really surprising, to see this happen because we have more and more programs around who can take care of patients with congenital heart disease. They just don't know it.
And that's specifically what the PACC program is focused on.
That's exactly right. So we're the only program in this region that provides care that's comprehensive and directed to patients with congenital heart defects of all ages. We typically focus on teens and adults, but I'm based within a bigger congenital cardiology group that provides care throughout the entire region.
Let's talk about some of the signs and symptoms, and again, can present differently for men and women. But I guess specifically maybe if someone is starting to have a heart condition, and there are some screenings available if you have a family history. How often does family history come into play?
Sure. I mean, family history is absolutely important. It's part of a bigger picture, so we don't look at that alone. There are multiple risk calculator tools that are available. So we really recommend that every adult should really kind of confer with a provider and undergo risk stratification. And that involves looking at blood pressure, cholesterol, family history, etc. And then we can estimate what the risk of development of cardiovascular disease is in the short and long term. And then depending on where you end up, kind of in which bracket, there may be some additional testing that may be helpful to screen for existing evidence of cardiac disease.
So people that are trying to be proactive, can they just schedule a screening? What types of screenings are available?
Right. So that's a very good question. And there's a lot out there. It can be overwhelming. And I know some patients will see these sort of one-stop shops where they can go and they get screened from head to toe, in terms of kind of medical screening. And I think we need to be cautious when it comes to that. I think the better approach is to, like I said, meet with a healthcare provider and undergo a complete history and physical exam, figure out what the family history looks like, and then in particular for patients that are at intermediate risk, so they're not low risk, in which case we recommend a healthy lifestyle, but they probably don't need further testing or intervention. And then high-risk patients clearly need more aggressive risk factor modification. So you have this group in the middle where we're looking at a 10 to 20% 10-year risk of developing cardiovascular disease. And those patients can benefit from things like, for example, CT coronary artery calcium scoring. Sometimes that can help inform decisions about whether they need to go on therapy. There's some inflammatory markers that can be checked, some more kind of specific lipid tests. And so, again, for that kind of intermediate zone of patient, I think there are some tools out there. But I would really caution the general public about undergoing testing without having kind of the preliminary steps in place.
Mm-hmm. Let's talk about signs of a heart attack in men and signs of heart attack in women, because they do present differently, and that's, overall one of the things that people are most concerned with is having that event. So for men, what are we talking about? How will a heart attack present itself? Cardiac arrest.
Yeah, well, coronary artery disease can present as a sudden cardiac arrest or sudden cardiac death, and that can be no symptoms at all until right before the event. And that's one of the scary things about heart disease, is that a lot of people can have it happen without really any warning symptoms. But there is another group of patients that may have weeks or months or even years where they may get some chest discomfort, a tightness in their chest, a squeezing sensation, a burning sensation.
That can go on for months?
Well, the symptoms they may notice periodically. Okay. It may come and go, but they can experience it for some period of time, and they're in denial. They think it's acid reflux. They think it's something else. Well, it only came on this one time, and it starts to happen more frequently. That can be kind of an escalating type picture, which we often see. But those are some of the symptoms they can experience. We consider some people stable when those type of symptoms come on predictably. Like if I go out running, I start to get a little tightness. That person may have a different prognosis than the person who gets a sudden episode of chest discomfort while they're watching TV or while they're doing something around the house. That could indicate things are a little more unstable with their heart, and if these symptoms don't resolve quickly, can turn into a life-threatening emergency. So certainly anyone that has new onset symptoms need to report to their physician. If they're at home or if they're out somewhere and they get these symptoms that don't go away within 5 or 10 minutes, they probably need to seek emergency care.
Okay. Some of the other things we're seeing on the screen right now include the lightheadedness, maybe vomiting that can come on, jaw, neck, or back pain included. That was something I hadn't realized.
Right. Yeah. I mean, beyond the typical symptoms are mostly in your sternum. The body has a complex nerve system, and a lot of the nerves that provide sensation and things to the heart also are the same ones that go down your arm. So people will feel this pain down their arm. They're also the ones that go up into the neck, and so that's why these symptoms are referred, or you can also experience them in these ways. Sometimes a person's only discomfort may be a throat type of pain or a burning there, and so it's challenging. And that's why a lot of patients sometimes will dismiss their symptoms because it's not what they've read in the textbook. And so I think the biggest thing is making people aware when people get to be in their 40s and 50s, their regular doctors should be talking to them about some of these signs and symptoms so that they're prepared when something comes up or when to know things aren't quite right and to get it checked out.
And we've learned it can be different for women when it comes to presenting.
Sure. So primarily men have a more classic presentation of, I feel like an elephant sitting on my chest. But women tend to describe nausea, sometimes pain in their belly, a lot of times up in their jaw or their teeth is where they experience the pain, as opposed to feeling it down their left arm, classically, I would say.
And they will often dismiss it. Women will.
I think the education is getting better, but yes, that is true.
At what point what is the alarm for people? What do they usually get to a point where somebody else is ending up having to call an ambulance or a doctor because you don't recognize it yourself? It's extreme. It usually gets to the extreme point.
Right. So I think if you're having some of these symptoms that are unusual for you and they're sustained, they're persistent, and I think if there's any question, the textbook may say one thing, but I think if you're having any symptoms that you feel are abnormal and they're persisting, then I think the best course of action is to go in and get checked out. And it shouldn't take somebody else to push you in. That's actually one of the reasons why men tend to do better, is because often their wives will sort of force them to go in to get evaluated, and it doesn't necessarily go the other way. And so, but I think just the general advice to those listening would be, if you're worried and symptoms persisting, not going away, you really just ought to go in and get checked. Better safe than sorry.
If you have a congenital heart defect, do you have a heart attack, or is it usually something else that comes on?
Well, heart attacks can happen, but it's rare in our patient population. Usually they're developing arrhythmia or signs of heart failure, and those are the most common reasons for patients to require hospitalization. There are patients who have survived and done well and then go on to develop acquired heart disease on top of their congenital heart disease. And that's where specialized care can really be helpful. You have someone who understands not only their heart defect, but also knows a thing or two about coronary disease or heart failure and can provide that comprehensive approach.
Well, a lot of people with heart conditions are able to improve or even reverse their condition with diet, exercise, or lifestyle changes, but not for one Spokane woman with cardiomyopathy. And she had to learn to live with that condition, which she acquired in a very unexpected way.
Human Resources, this is Katie. Can I help you?
I am a type A driven, achievement-oriented person. So when this happened, I just thought, all right, let's address it, let's get it done. And if one thing I've learned, it is that I am not in control.
Katie Brouillet is an active mother of two, 18 years into a career as a senior executive for Washington Trust Bank, and she suffers from cardiomyopathy.
And it put me in the category of heart failure patient, which was really, of course, disturbing to hear that. And I did what every professional would do. I went home and Googled it and immediately thought I'd be dead by morning, because that's the worst thing you can do.
It's described as a wiring issue in the heart. Medication helps, but her condition cannot be improved through lifestyle or diet management. No matter what she does, she is always at risk.
Sudden cardiac arrest is basically just unplugging the light bulb. And if that happens, you just fall down. There's no warning.
There's also nothing unusual she did to bring on her condition.
They asked me lots of questions. Do I remember having a childhood virus or going to the hospital or having something really damaging?
It turns out all Katie did was get pregnant.
So basically it was determined that the hormones while I was pregnant damaged my heart.
There were cardiac issues during her second pregnancy. Katie was monitored throughout the pregnancy, and after giving birth, the follow-up tests looked good. It would be 4 years before she had a diagnosis of pregnancy-induced cardiomyopathy.
So when you say, kids break your heart, they can. They really do.
There had been symptoms along the way, but she passed them off as the result of a busy lifestyle.
Well, I do get out of breath now and then, but it's also just because we just built a house and I'm busy working and, I'm just out of shape.
The flow of blood through her heart had dropped to a level that was very concerning to her cardiologist.
Dr. Christensen said, we're going to do our best to reverse this cardiomyopathy, so we're going to just make your heart relax and see if it'll heal. So she put me on all sorts of medication, starting with beta blockers, which if you've ever been on those, the side effects just kind of, every day at 2, you just feel like you're in molasses.
Her levels rebounded, and a year later, the effects of cardiomyopathy were reversing until she crashed again.
So I've learned again, I'm not in charge, I can't control this. Life is going to be a roller coaster. This isn't just one and done fix. It's a journey.
Katie says the best way she can help herself now is to enjoy the lifestyle she has and stay in tune with her body.
Listen to your heart. I now know if I'm doing things, I know exactly how many beats per minute I'm at that moment, because I can feel that I'm just really out of breath and I have to stop and breathe, which is probably good advice for us all the time anyway. Just stop and breathe and take a moment and then start again.
So Gretchen, I was really surprised by this. It's a condition I had never heard of, this cardiomyopathy brought on by pregnancy. Talk a little bit about that.
So there's 2 types of cardiomyopathies, generally speaking. There's ischemic cardiomyopathies that are brought on from having coronary disease that we've talked about before, and then there's non-ischemic cardiomyopathies. So a pregnancy-induced cardiomyopathy would be in that category of non-ischemic cardiomyopathies that can be brought on by several different things. Viruses are pretty common, alcohol, pregnancy, and some drugs, and sometimes we just never have an answer for why that happened. And obviously in hers we point to pregnancy, but there's a lot of research being done with regards to the genetic factors that affect people developing non-ischemic cardiomyopathies, and there's a lot more to learn about it, but it's a pretty interesting topic.
Mm-hmm. Could it have been brought on by something that happened when she was a child? There is some indicators that she may have had a virus that damaged her heart and then it came out during the pregnancy?
Yeah, it is possible. Some children and adolescents develop a viral syndrome that leads to some mild heart dysfunction that perhaps doesn't show up at the time, and they're maybe programmed to develop problems with their heart in the future. So it's a little bit hard to know, hard to predict. That makes it kind of scary too.
So there isn't any way to tell until something comes up?
Often that's the case. There are some cardiomyopathies that develop in families, And although hers may not be that form, when we start to see more than one family member having heart dysfunction or symptoms of heart failure, we start to look and see if there's some underlying genetic association between all of those patients.
Mm-hmm. I was really struck by her attitude. She has a very positive attitude. She knows what she can do and what she can't do. How important is that?
I think it's really important to have a positive outlook on things, because with the field of heart disease, there's some things that you can control and there's some things that you can't. Some of the things like that was brought on by her, or some of these viral things that you just can't control that. And so having a positive outlook, trying to maintain an active, healthy lifestyle, trying to influence others, be an example, teach other people, get it out there. She's doing a lot of positive things, and there's a lot to applaud her on.
Okay, we're starting to get a few emails this evening, and we have one from Dorothy, who is asking, how big a role does stress play in heart disease, and especially AFib? Dr. Muaz.
Sure. So thanks for the question. It absolutely plays a role. There's a clear association between stress and the catecholamine and kind of stress hormone release that can be associated with that, and worsening of some cardiac conditions. In fact, in the recent decade or so, we've identified a condition called stress cardiomyopathy, or broken heart syndrome, which is felt to be exclusively related to an excess of these stress hormones that causes weakening of the heart. And so clearly it can be pathologic or cause problems. When it comes to atrial fibrillation, we know that there are various triggers, and stress can be one of them, because those stress hormones can cause the heart to become irritable, so to speak, and so for some people that may be a trigger to kind of set them off into atrial fibrillation. And for those that are unaware, so atrial fibrillation is an arrhythmia that originates in the top chambers of the heart and has a number of other issues associated with it. So the short answer is yes, there can be an association.
Okay.
Yeah.
And we have one from Julie in Idaho, who is asking, can any of the cardiologists discuss Prinzmetal angina? Am I saying that correctly? Symptoms and treatment. Anyone?
Yeah. Prinzmetal angina is a type of angina where instead of occurring due to a blockage, it occurs because the blood vessels of the arteries of the heart actually spasm down. And so the heart muscle itself doesn't get as much blood flow, just like a heart attack would due to a blockage. But in this case, it can be kind of a stress response or hormone related or something like that. But the blood vessels will actually spasm, and so the people will feel discomfort and things like that. And that kind of falls along a spectrum of heart disease where it's what we call microvascular angina, where it's not necessarily the big arteries of the heart that get blockage, it's sometimes the very small arteries of the heart. And so people feel the same way, but yet a stent or certain typical medications don't solve the problem, and so they can have a lot of the symptoms, and it can be difficult to treat. And the other hard thing about Prinzmetal's angina is that it can be hard to catch. You can order a stress test and it shows up normal. You can do a heart catheterization and sometimes find no blockages, but it's something that's a dynamic thing. So it can be challenging, but there is treatment out there, and most people do get better from it, and it's the prognosis is good.
Mm-hmm. Let's talk about some of the things that we can control when it comes to heart disease, and those pieces would be our weight and the stress level. There are also treatments, we can get into that too, but what are some of the things we can control that we need to get under control to make sure that we have a healthy life?
Smoking cessation is the biggest one.
Stop smoking.
If you have diabetes, getting that under control, those are huge risk factors. But obesity is a huge epidemic that's just getting worse in the United States and around the world too. So having a healthy lifestyle where you are maintaining good weight and exercising 30 minutes at least 5 times per week is definitely recommended.
Mm-hmm. Good weight. What does that mean? What do we need to check? I think people, there are broad ideas of I need to lose weight, I need to exercise, but specifically, what do they need to know about their weight?
Does anybody want to make a comment about that?
Well, so the body mass index is kind of a good marker for most people to assess how they're doing. I have a body mass index chart in every patient room, and when I talk to patients about their weight, I pull it out and I show them, for your height, this is the weight you ought to be, and this is where we want you to go. And let's not go there immediately. Let's set small goals to get to your ideal weight. But the BMI is a pretty good marker for standard weights. Many people have noticed that generally most of us are all gaining weight. And so what is normal these days is different than it was in the 50s. So having some marker, some objective number like a BMI can be helpful.
And how you carry your weight can be of concern too, especially around the midsection.
Right, exactly. No, I agree with Dr. Nicolarsen. I think BMI is a good screening tool, and I mean currently 70% of Americans fall into the overweight or obese categories, and about a third are obese. And you're right, the type of obesity matters. So men tend to carry their weight above the waist, and women tend to carry it below. And that apple-shaped figure where you're carrying the fat in your abdomen definitely correlates with increased risk, as opposed to other distributions of fat. And so I think as a tool, BMI is good, and then you can get into sort of the fat distribution and percentage.
Mm-hmm. When your patients ask you about diet, what do you tell them?
That's a great question. I think there's probably a lot of different opinions on the matter, but when patients approach me, I think, like Gretchen talked about, is most people are overweight. They have high blood pressure, high cholesterol, diabetes. And so the biggest thing is just reining that in. And so while there's some debate in the medical community about which diet may be better for different people, or one may lower cholesterol more, or this one may be better for weight loss, I think the biggest thing is finding something you can stick with. I think people need to make lifestyle changes. It's not necessarily do I lose 20 pounds or whatever the number is. It's about making healthy lifestyle choices. It's about eating better regularly. It's about getting more activity. It's about doing those things that's going to propel you, not how much weight did you lose in the last couple months. And so that's what I try to promote with patients. The best diet is the one that you're going to stick with, the one that fits with your lifestyle and that you can stay with.
Mm-hmm. Often women want a guide. Give me something to work with. Do you recommend any particular diets, the Mediterranean, or staying away from some?
Yeah. Probably the Mediterranean, but more than diet, I actually mostly promote being active, because there's more, people have greater benefit from just being active than actually the weight loss itself. So that's what I promote.
Mm-hmm. And I would piggyback to that is that we think of weight and cardiovascular health, but activity promotes, muscle, joint health. And as we get older, those things are just as important for your health. I mean, the leading cause of, or not leading cause, but one of the biggest things as we get older is we get frail, we fall, we injure things, we hurt joints, and each one of those can be a significant setback in your lifestyle. So being active is just as important as anything.
Mm-hmm. And if I may, I might
Please.
add to that as well. The activity is important for a lot of reasons, as you've heard. But one thing I want to make sure that people understand is you can't exercise enough to lose weight. It really has to come from a change in your diet, and you have to change the amount of calories you're taking in. Many people aren't going to exercise enough. And if you do start exercising, don't think that means you can eat that second dessert. It really needs to be a balance. And I think focusing on calorie restriction is an important way. Regardless of how you get there, cutting down on the calories and the portion size matters.
Mm-hmm. And when it comes to activity, do you want just cardio? Do you want to make sure you're doing weights or weight-bearing exercises? What do you recommend there?
Yeah, it should really be a balance. The current recommendation, as Mrs. James referenced, is 150 minutes of moderate activities that the American Heart Association would recommend, and that would be some degree of cardio, or you could do 75 minutes of more strenuous exertion per week. But that should be balanced with flexibility and strength training, and really kind of looking at a whole body approach. And when we see patients, I see patients in clinic sometimes, a 70-year-old man that looks like he's 60, and inevitably it's because they've been active, and it's been a combination of various activities. So absolutely. And then I just have one comment as far as the diet question. I'm sure we all have our opinions on this, but I really think that the data has increasingly shown that probably the number one culprit for the obesity epidemic is processed carbs. Mm-hmm. And so I don't know what the rest of the panelists feel, but my personal view is that that's kind of the number one thing to avoid, and then you can discuss kind of where to go from there.
Mm-hmm. And we used to think fat was the enemy. Now it's sugar.
That's right. In the last 40 years, I think there's been a big paradigm shift. Yes.
All right. We have another email from a viewer saying, best practice for living with LBB, left bundle branch block. Who would like to answer that?
Well, I was going to say, a left bundle branch block is a delay in the electrical system from when the heart initiates the heartbeat at the top to when the muscle at the bottom actually beats. And there's a couple different electrical wires that go to those different parts of the heart, and if one of them has a little bit of a delay, it can show up on an EKG called the left bundle branch block. Sometimes it can be a marker of a disorder that they were born with. Sometimes it can be an acquired heart defect, like our video demonstrated. Sometimes it can be a marker of coronary artery disease, and sometimes it can just be you. And so it's definitely worth seeing, your physician, knowing what your baseline is. Most of the time we get an ultrasound to see if you've acquired a weakening of the heart muscle. But there are people that have no weak heart muscles, no problem. It's just an electrical delay. You've had it your whole life. And it may have some long-term implications to it, but it may be something you just live with and have no problems. And so as far as how to live with it, it's number one, figuring out what the cause is. And then once you know what the cause is, which category you fit into, your physician should be able to give you the best recommended advice going forward.
Okay. We have an email from Andu who says, I'm 62 years old, and when I was sitting and typing on my computer, suddenly I felt like some energy going from the tip of my hands all the way to my forehead and stopped there, and I felt very weak. What could that have been? Does that fall into the heart category, possibly?
So that's a tough one. I think it's unlikely. I think to be heart related. Sometimes some arrhythmias can present in kind of an unusual fashion. I would say that probably worth discussing, with kind of a primary care provider and exploring from there. But I'd say it's a little hard to say based on that description alone.
Sounds to me like a really powerfully written email or note or whatever he was writing.
Could be. We appreciate that. Thank you. Do we still need to know our numbers? And when we say know our numbers, what are we talking about?
Are you talking about cholesterol?
Yeah, the cholesterol.
I think it's
used to be a rundown of the numbers.
For sure. Yeah, because it's a measure of your risk, so that your cholesterol, your blood pressure, your BMI, and whether you smoke or whether you have diabetes and what your family history is. Those are kind of the basic risk factors.
And I think we are moving into an era of medicine where everything's a lot more individualized. We're seeing cancer treatments that are very specific to your unique tumor, your chemotherapies that are on that. And I think heart disease it hasn't traditionally been that way, but I think we're seeing with a lot of the new guidelines it becoming individual risk-based. And so what is your family history? What are things you're contributing to it, whether it's smoking or other risk factors? And so it really is becoming much more personal. You should know where your numbers are at, what you can do to affect them. But unfortunately, there's some things you can't control. We're all getting older. Sometimes gender plays a big role in it, but you certainly want to make sure you're doing all you can.
Mm-hmm. A lot having to do with treatment. We can get into some of the medications, surgical procedures, but specifically statins have been debated recently. Talk about the use of statins.
Sure. Do you want to start or should I?
I know both of you want to talk about that.
I think most cardiologists are going to feel fairly passionate about this issue because it's a big part of our daily practice. But I think a good starting point is to say that statins are among the most studied medications in all of medicine, not just cardiology, but all of medicine. And there's absolutely no doubt that they work. We started the segment talking about how there's been a decrease in cardiovascular deaths, and statins have probably been the workhorse of that decrease, or one of the workhorses. And so I think it's very clear that they're effective. Just to give you an example, so there was a meta-analysis, which is a study of multiple studies, looking at 170,000 patients. And if you decrease your bad cholesterol, your LDL, by about 40, that equates to about a 22% risk reduction in terms of heart attack and stroke, and a 10% decrease in mortality. So those are for patients treated with statins. So they're very effective. And then we can get into sort of the side effects and some of the issues that patients have with them.
Mm-hmm. Yeah, no, I agree. It's been one of the workhorses that we've had to reduce cardiovascular risk, and it will remain so going forward. There's all sorts of new treatments coming out that may prove more effective, but right now they're prohibitively expensive. A statin is something that even on some of the generic pharmacies, you can get a prescription for $4 a month. So even if you don't have insurance, it's something you can afford. And it's going to be a very potent medicine that can reduce your risk of having future events. And some of these patients we see in the clinic, we may start them on initially to prevent heart attacks. But once you've had a heart attack or once you've had a blockage, these are medicines you should take the rest of your life. And it's a challenging topic because patients don't like to take medicines, understandably. I mean, who likes the idea of saying, I need a pill the rest of my life? But everything we do in medicine is to reduce your risk of future events. And so it's individualized whether you want to take that pill to reduce that risk, but in general, we strongly recommend it. But a lot of patients are led astray. A lot of stuff on the internet is negative. And while there are some side effects to be aware of, mainly muscle aches and joint pains, that doesn't happen to the majority of the people. And just like anything else, is sometimes the most loud or what's making the most news isn't always what's accurate. And so I think a lot of people are unfortunately getting led astray with maybe bad information. And so we do spend a big portion of our practice trying to dispel some of these myths and hopefully give patients good advice.
We have a phone call from Bob in Post Falls. Bob, thank you for holding.
You bet.
You have a question?
Yeah, I've had COPD for a number of years now, and I'm starting to get into the exasperation deal. It's pretty tough to get around. And it's really turning up the heart rate. And it gets to where it actually hurts. And I was wondering, I don't know what to wonder. Is there anything that can be done for that?
So did Bob say COPD exacerbation?
I believe so. Bob, was it COPD?
Yeah, it's emphysema to get right down to the bottom line of it.
Yeah, I mean, I think that if you're having some chest discomfort with your COPD exacerbations, we know that lung disease, particularly COPD, which is often seen in patients with a history of smoking, can coexist with heart disease often. And so I think if you're having chest discomfort, then that's worth investigating to make sure that it's not just the lungs and that there isn't also a cardiac condition that needs to be addressed. So I think it's worth talking to a physician about.
Agree.
Yeah. Is that fairly common?
It is fairly common because, again, as we've referenced a couple of times, smoking is one of the major risk factors for cardiovascular disease, and that's the most common cause of COPD. So it is pretty common, unfortunately, that the two go hand in hand.
Mm-hmm. We have Jack in Tonasket. Hi, Jack.
Hi. Yeah, 5 years ago I was diagnosed with AFib, and I have erratic heartbeat, and I don't have symptoms at all. I can't even feel anything when it does it. But I work out all the time. I'm 69 years old, and I hike all the time, still up in the mountains, and then I work out about 5 or 6 days a week. And I didn't have any symptoms, but I did have ultrasound, and everything looks great and all that. But I was just curious. It's an electrical problem, I guess, is what they say. But I'm kind of wondering what brought that on, I guess, or what do I do about it? Or I just, just keep working out and do everything with no pain and hope for the best, or what?
Yeah, I mean, for the majority of the program so far, we've talked a lot about blockages and heart failure, but there is a whole other category out there of electrical problems that can occur with the heart. We mentioned the left bundle branch block, but there are other things. Atrial fibrillation is probably the biggest rhythm problem that we see, and that's a situation where the top of the heart may beat separately from the bottom of the heart, and so the heart becomes a little more irregular. The biggest risk with that condition is that it puts people at risk of having a stroke. Some people can feel it. They get symptoms. They feel their heart racing, pounding, fast heartbeats, and some people don't. And so it can be just as life-threatening from the risk of stroke and other things, but it can be difficult to manage. As far as activity, I would encourage you to be active. There's things as cardiologists we do to see when you're in the irregular rhythm, what your heart rate behaves, what type of activity you can do without pushing it to the limit. There's all sorts of treatments and medications we can do to slow your heart rate down. Sometimes we try to keep it in rhythm. Sometimes if you're not feeling it, we may not. It's a situation that can be well controlled with medicines, but it's really an individualized type thing. So it's something we should sit down, or someone should sit down and make sure they're going over all your risk for stroke and that we're treating the rhythm problem well. But it's a good question. I'm glad you brought it up.
And it sounds like he exercises regularly and he's active, and maybe a little concern in his voice about doing that.
Yeah, and I think I guess he brought up too is what caused it. And atrial fibrillation is one of those diseases or those problems that sometimes can be insidious. Things like long-standing high blood pressure, sleep apnea, being overweight are some of the traditional risk factors. Heart failure is something we can get that causes the heart to be enlarged, and that can make it more prone to going out of rhythm. But it is a very complex thing between the heart muscle and the electrical system.
The biggest risk factor is age. So,
age,
so it may just be you got too old, and it may not be anything in particular. But,
as the population continues to age due to the advances in our healthcare, we're seeing a lot of these problems. We're dealing with them in people 70, 80, 90 years old, and it's an individualized thing.
With your patients, Dr. Nicolarsen, I know you stressed to me that it's so important that they continue to get care and to seek care as adults, especially when they were born with a heart defect.
Absolutely. It's really, really important. Many times we see patients who are coming in with a problem. They haven't been seen in years, and they're showing up in the emergency department.
And are they surprised by that often?
Sometimes, yeah. I mean, they thought they were cured. You said it earlier. And that was the message that was given to patients and family members years and years ago. But nowadays, we're really careful not to say you're cured. In congenital heart disease, you're never really cured. This is a heart problem that you're going to have for the rest of your life and can show up when you least expect it. And so the most important message that I want to get out about this is that if you've got congenital heart disease, that you stay in care. You stay with someone who understands the complex nature of your heart defect and knows what to anticipate if it were to get worse, and then what to do if it actually happens. And so it's really, really important. There was a study back in 2012 looking at the adult congenital heart disease programs in the country, and they surveyed every incoming patient, and they said, when was the last time you were seen by a cardiologist? And many times it was shocking at the numbers. Half the patients sometimes hadn't been seen in at least 3 years. Even the most severely complex patients, 1 in 4 of them hadn't been seen in the last 3 years. And these are people who we see twice a year at least. So it's a remarkable problem, and unfortunately it's not getting any better.
Mm-hmm. And with the program that you run, the PACC program, part of that piece, a key piece, is the support groups and these people getting together and making sure that they're there to support each other.
Absolutely.
Yeah.
Patients are telling us they want to find out who the other patients are with their heart problems. They want to get talking. And actually, one of the biggest and most comprehensive programs for patients with congenital heart disease is the Adult Congenital Heart Association. And this is a national organization that was founded by patients with CHD in the late 90s. And they got together in Boston and said, we got to do something. We got to help each other. And now this is a national program that is really impressive, active politically, supports patients in many ways. And so we like to work with them and help our own patients here locally.
And that can really be said for just about any disease or condition. Women need support too, and I know women will quite often turn to their friends when they've had a heart attack or a condition that affects their heart.
Yeah, there's kind of an interesting registry that started at Mayo Clinic a while back with this entity that's primarily happens in women, and it's SCAD, or a spontaneous coronary artery dissection, and it's in women who don't have really any risk factors for coronary disease, and their arteries suddenly spiral, and sometimes they end up needing stents, sometimes they have had bypass surgery. But what they've found through this registry, that one woman started by kind of talking to different people on the internet that have had it, and then now they have a large registry. They found that treating it is better, just leaving those arteries alone. So it's kind of interesting.
And that's just a random condition that can happen.
Well,
fairly random.
We don't know enough about it yet,
Wow.
I guess, to know that it's not random. But it does happen in women primarily. Sometimes it happens close to the time of a birth. Happens in some people who are doing strenuous exercise. I don't know what you've seen it before. And
yeah, we do see people can get tears in their main aorta. Dissections are called. It can be a life-threatening condition, and we can also get tears in the coronary arteries. And it tends to occur around the time of childbirth or at menopause. And so there's probably a strong hormonal link. It tends to be really peak in those type of incidents. And so, a 50-year-old female that comes in with a heart attack that's healthy and runs, it can happen. And it can be due to this tear in the artery. And sometimes it turns out, well, and we're able to get it taken care of. And sometimes it can be, life-threatening, devastating, or even fatal.
Any symptoms?
Typical to what you'd see of a heart attack, whether you're male or female. I mean, there's a tear in the artery, so their heart is not getting the blood supply it needs. So that heart muscle is feeling pain, discomfort, or whatever it is that that person would feel.
Okay. We have a phone call from Pam in Red Deer. Hi, Pam.
Hello.
And you have a question?
Oh yeah, I just want to know. I am using Coreg, and does that drug cause joint pain? Eventually, I started on Coreg in August, and gradually I am having joint pain. So I was wondering whether that is the side effect of that medication.
Yeah, so what Pam is experiencing is not a common side effect of that drug, of carvedilol or Coreg would be the brand name. It's a beta blocker, one that we commonly use in cardiology for a number of applications. I'd be curious if it's related to maybe one of your other medications or maybe unrelated to medication altogether. I mean, that's kind of a non-specific symptom that can be caused by a number of different things. If you're still suspicious, the issue with these medications is if you look at the actual registries, I mean, probably almost everything's been reported, less than 1% of the time, but it's conceivable. And so you could always talk to your provider and maybe get switched to a different beta blocker and see if your symptoms resolve. But I'm not sure. It's not something we commonly see.
And I would add, too, is that sometimes as providers we do have people stop a medicine for a week or something, but we know their history. We know what condition they have and when it's safe to do that. There's some conditions, congenital heart disease, heart failure, things like that, where stopping that medicine could be very dangerous. So if you're concerned about it, call your physician and they can see if maybe switching medications or even stopping it for a little bit would be appropriate for you.
Okay, but only do that with the advice of your doctor.
Yeah, I would not do that without discussing with them.
All right, very good. We have an email from Adele in Coeur d'Alene, and she writes, would you please discuss pre-hypertension as it relates to the new blood pressure guidelines? And we've seen those guidelines change. Who would like to tackle that? Dr. Abudiab.
Am I on the hook here? You're a preventative cardiologist. I hope we're all preventative cardiologists. So pre-hypertension. So I think the general shift in terms of hypertension guidelines has mostly applied to older patients where we've become a little bit less aggressive with treatment of blood pressure in later life. But I'm not sure how old the emailer is, but if you are younger, below typically cutoffs of about 75 in terms of where we tend to kind of de-escalate and be a little less aggressive. So pre-hypertension is basically before the diagnosis of kind of formal hypertension and before where we would recommend institution of therapy. And so I think that's really just more of a wake-up call to say that let's look at some of the potentially reversible factors that may be contributing to elevated blood pressure, whether that's control of weight or implementing exercise, maybe some other dietary features, etc. So bottom line is you're kind of in the warning phase, and I think it's a good opportunity to look at some things to change. Mm-hmm. Yeah.
What are the good numbers? I mean, I know it can be specific to age, but kind of a broad spectrum.
Right. So typically for older patients, we'll typically tolerate, or our treatment goals are 150 over 90 for elderly patients. And then younger, we're typically targeting 140 over 90. Now that is not the case if you have other pre-existing conditions. So for example, in diabetics or patients with coronary heart disease, we'll often target more aggressive numbers, looking for more like 130 over 80 or below. But for the general population, those 140 to 150 over 90 numbers are good to remember.
And to piggyback off what he said is blood pressure is one of those things that doesn't have any symptoms. And we think of blood pressure as something that can cause long-term problems. And so what you're willing to accept in a 80-year-old isn't what you're going to accept in a 50-year-old. And so we are going to be a lot more aggressive with those younger individuals because he's going to have years of potential complications. And so, again, back to what we'd said, it's individualized, and one number, one shoe doesn't fit all.
And Gretchen, would you recommend the same for women?
Oh, yeah, for sure. And we see a lot of 80 and 90-year-old patients, at least I feel like I do lately, and I'm actually finding myself frequently backing off on their medications because as we get older, our pipes get more stiff. And, you know, the statistics on if you break your hip because you fell because your blood pressure is too low, that's a real thing. And so I like that the guidelines have changed in the last about 5 years ago.
It's sort of finding that happy medium between the medications and the age and where they're at lifestyle-wise.
But if I had a patient like this woman that we learned about earlier that had a blood pressure in the 90s for like 90 over 50 and she was completely asymptomatic with it, I'd say, great, we're not going to change your medications at all. So it really just depends on the patient and the problems.
Okay. We have an email from Belinda. She writes, how well is heart ablation as a control for AFib? I'm already one of the docs. Want to tackle?
Oh, I'm already on amiodarone.
Thank you very much. We're getting very technical.
Yeah, as we've advanced over the last 10, 15 years, we're finding alternatives to just pills. And one of the procedures has been an ablation therapy. And what that is where they take a catheter or a tube and they can go in through the veins into the heart and actually zap part of the heart that's causing these electrical signals, and so they alter the way the electrical system in the heart conducts. And so there's several techniques for doing that, but in general, ablation is considered one of the most effective ways for treating atrial fibrillation or controlling the symptoms of it, but it's not appropriate for everybody. Some people can be put on a medication that has low side effects and they do well for years or even longer term. And then there's some people that despite medications, they're still having a lot of symptoms, it's not getting adequate control, and an ablation is a good option. There's some people that ablation is a good option as the first line. It really comes down to a personalized, tailored approach, but it is an invasive procedure. It does carry some risk, but for her, it may be the best choice.
Mm-hmm. And how are you? Is that a screening process then to determine that?
Yeah, there's within cardiology, you have people that do preventative cardiology and non-invasive imaging. You have congenital specialists. You have people that specialize in stent procedures, and you have people that specialize in electrical arrhythmias. And so the ablation procedure falls within the realm of what they tend to tackle. And so general cardiologists may make the diagnosis, get them on the basic treatments, but once it starts being a little more complex or someone really has a strong interest in ablation, they usually see one of the electrical specialists, the electrophysiologists.
Mm-hmm. We've learned a lot about sleep playing a role in staying healthy. Does that also come into play when it comes to our heart health, making sure we're getting enough sleep and proper amount of sleep?
Absolutely. In fact, that's a good segue from Belinda's question regarding atrial fibrillation, because there's actually an interesting study that looked at success rate of atrial fibrillation ablation, which she was asking about. And in patients that have a lot of reversible risk factors that are obese or have untreated sleep apnea, which is a sleep disordered breathing, actually addressing those, losing a substantial amount of weight, getting the sleep apnea treated, may actually approach the efficacy of getting the ablation, believe it or not. Which, if you can have a non-invasive treatment, that's always preferable. So sleep is certainly important, and I think the thing that we see a lot as cardiologists is the issue of sleep apnea in particular. It's an under-recognized and under-treated problem, and it has a very strong association with a number of things: heart failure, atrial fibrillation we just talked about, and so forth.
Mm-hmm. And that can often be somebody who snores a lot?
That's right. So in terms of kind of what we ask for screening, if I have a patient in my office and I'm kind of wondering if that could be the case. So the body habitus can be suggestive. They tend to be overweight, snoring or stopping breathing at night, headaches and not feeling well rested in the morning, and having difficulty with sleepiness during the day are some of the things that would potentially raise a flag.
Mm-hmm. Touch on alcohol. We know, or we've learned, that red wine can be a positive thing, but it can also be too much, in moderation, I guess. What are some, how much alcohol, any alcohol, do you recommend? Dr. Wallace.
I don't recommend alcohol intake in my practice at all. No,
Okay.
there is data that up to a glass of red wine a day may be healthy, but once you get more than that, you lose any of the benefits and it can be harmful. And so I don't know too many people that like to stick to their one glass of red wine a day, and so I don't find that prescribing that is helpful at all. And so I generally recommend avoiding it. Obviously there's a lot of people that do social drinking, and I don't think for their frequency that probably doesn't play a big role at all. But people that do drink to excess can develop heart failure, like our video demonstrated. They can develop similar things in that non-ischemic cardiomyopathy category, and it can be a life-threatening problem. And so, there's no amount of alcohol that I say is good for you and you should regularly participate because it's going to offer you better health.
And how much really is a glass of wine these days? I feel like the glasses are getting bigger and bigger.
Are getting big. What about for your patients that have a lifelong condition?
Yeah, I mean, it definitely matters. Some of these patients, many times the 18, 19, 20-year-olds who are going to college are in college, and they've got a heart problem, maybe an arrhythmia, maybe AFib. And alcohol can precipitate those arrhythmias often, and so I'll counsel them on that. And so it definitely matters. It really does.
And I think that's a good reason why some of these people that have congenital heart disease should see a congenital specialist, because those are things that their primary care physician might not think about. A cardiologist who's just seeing them may not have those unique aspects. And so, someone that has specialized training in that is going to think outside the box and probably give them a more personalized approach and advice that's applicable to them at that stage of their life.
Okay. We are drawing close to the end of our program tonight, so I'd like to get some final thoughts from each of you on something you'd like to leave our audience with tonight when it comes to heart health and staying heart healthy here in Heart Month. And Dr. Abudiab, let's start with you.
Sure, thank you, Teresa. So I think we've touched on some very important topics tonight, and hopefully the audience felt it was beneficial. I think my recommendation to everybody is to go meet with a medical provider and to undergo risk stratification. And again, that may be as simple as just telling the medical provider about your history and having an exam done and stopping there, but typically involves some additional parameters as well. So that would be one takeaway. And then the other, I think, is just an emphasis on diet. I think that's really what we as a country need to be sort of emphasizing, and I think that we have a lot of work to do there.
Mm-hmm. Gretchen?
So 1 in 8 women dies of breast cancer, and I think that in the United States, many people are aware of that, but 1 in 4 women dies of heart disease. And so I think it's important that as women, we think about heart disease as something that affects us and not just men.
Mm-hmm. Dr. Wallace.
Yeah, I want to echo everything that's been said already here on the panel. I would just encourage people to, take pause, see where they're at in life, see what they can change, and meet with a medical professional. I would much rather have a patient come to me saying, I can't quite do what I used to do. Is there something going on? And work through it with them, get a series of tests. And I would love the discussion at the end to be, you're just out of shape and it's okay to keep working and get back in the gym. But, we need to take these things seriously, and denial is not going to be the right answer. So sit down with somebody, we'll work through it, and we'll come up with a game plan for you.
Okay, and finally, Dr. Nicolarsen.
Well, congenital heart disease is the most common birth defect, and 1 in 100 people have it. And it's so common that sometimes people don't even know that they need to keep getting the care. And so my main message is if you've been born with a heart defect, come in and see us. It really matters. And if you have a problem that's diagnosed later in life, sometimes these are picked up in adulthood, get in and see us. We're here to help.
All right. Well, thank you all for being here tonight. We explored a lot during this hour. And that will do it for this edition of Health Matters. Our thanks to everyone who called or emailed a question. If you're looking for more information on heart health, we have posted some helpful links on our website. That's ksps.org. And be sure to join us for Health Matters on March 21st, when our focus will be bones and joints. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.